As a Parkinson's disease specialist with a practice that has more than 1,000 patients, I've had a lot of experience with seeing the problem of delayed on and other motor fluctuations for which an on-demand therapy like apomorphine is appropriate. General neurologists who see a few Parkinson patients who don't have that kind of day-by-day experience might not have as much interest in being overly invasive with therapies like an on-demand injectable drug like apomorphine. So I think it's important to think that the ball is in your court, that the buck stops with you, to use a few metaphors there, that when a Parkinson patient is coming to you and is getting gradually worse over the years, there's certain interventions that we can do something about. We can't help with the problem of balance. Sometimes that posture change also is impervious to therapy with medications. But off episodes do have something to be treated, and encouraging a patient to look upon their medication schedule, trying out extra levodopa intake, trying a dopaminergic agonist or a levodopa extender. All of these things are easy to do. They either work or they don't. A patient can get back to you in a few weeks as to whether that intervention has worked. Polypharmacy makes sense in Parkinson's if it achieves reasonable goals. And because quality of life is very much tied into optimization of medication, making this a priority, especially for a patient who's still working, whose quality of life and independence is in jeopardy. If there's a problem where stumbling and falling makes it of concern whether a patient should be living alone, these are issues that are really somewhat of not emergent problems, but close to it, especially if you have the option of changing their medication for the better. And so I would encourage looking upon off episodes as a very treatable part of the Parkinson patient's therapeutic options. We have a couple of ways that simultaneously can help, and sometimes I create a sequence of changes in medications at a visit with the thought that in 4 or 5 months, when that patient returns, I'll have some answers by then from just a simple phone call or an email as to instructions given to try this or that. In the case of apomorphine as an injection, the home titration service that is bundled into the product as we prescribe it has been very effective for me to find out whether a patient can tolerate it safely. There's been great skill in terms of that home nurse to talk to patients, to be available to give feedback, to go over the nitty-gritty details of how to put a needle on the syringe, how to dial in the dose, how to make the best use of caregivers if necessary. And I think you'll find this is a very satisfactory treatment option for many patients who have not even heard of this before. I find it very odd that many patients who've even been to other Parkinson's specialists haven't been told that there is the option of on-demand therapy, whether the inhaled levodopa product or apomorphine. And I would just encourage my colleagues to think of this as something that should be brought up in discussion, even if you're not prescribing it for your patient at that visit. It might be something necessary in the future.